Want to kick it off?
Yeah, hi. Welcome for this evening. Is there an echo bit in my? I'm in the basement. It's kind of
Sound
loud.
okay to me?
It sounds okay. All
Yeah.
right. Yeah. Thanks for everyone coming this evening. We're gonna have a short, quick presentation about shortness of breath. I have three cases from patients brought to the hospital by EMS in the last few months. So it's a little bit interesting. Justin's also on the line here. He's going to talk about this EMT residency program that we're trying to get together to, give specific EMTs, to sign up for it and try to get some experience within the hospital.
Thanks, Eric. So we have created an immersive EMT experience that'll enable you guys and girls to really kind of get a deeper understanding of the ins and outs of different departments in the hospital that are connected to emergency medicine, connected to a lot of what you do in the field. It'll be rotations through our emergency department, through our stroke area, through our cardiac cath area, and possibly on some other areas also, depending on availability. We have limited spots, and it's a 2 week period, and you pick a couple of days during those weeks that you would sign up for and attend for a full day session. So as I said, space is limited. If it is something that you're interested in, or at least interested in getting more information on, you can see on the flyer here, you can email brittany.colasanto@chsli.org. I'll put that in the chat feature, but also you'll find this flyer on our Facebook page. We had posted it today as well, so you can get a little of the details and get that email address also. In addition, just some cleaning options, housekeeping options for your non-core CME credit for today's presentation by Dr. Decena. You can email christina.woods@chsli.org. I will put that in the chat function as well. And we're going to do a roll call on the chat function. If you can also put in the chat function your full name, just so that we know that you attended. All right, Eric, all yours.
Okay. So this is like what the front of the building's supposed to look like for you. Those of you who haven't seen it, the plans from when the building's actually done. So just kind of exciting. We're hoping to have this open by the end of next year, if all goes according to plan. So today we're going to talk about shortness of breath. We're going to review three cases, as I mentioned, of cases brought to the hospital in the last few months by EMS. I'll quickly go over how we work up shortness of breath when you guys bring us the patients. And there are specific diseases. I don't want to give it away yet, because I want you to look through the cases and think what you think about them before we tell you what they are. And then there are some new treatments that we have for the diagnosis I'm going to be talking about that we provided Good Samaritan, which we didn't have a few years ago, but now we're a referral center for this specific disease from the other Catholic health hospitals. So we're going to start with three cases. Case number one is a 30-year-old female with shortness of breath, upper back and chest pain. So she's a 30-year-old female, had endometrial surgery 10 days ago, has a history of endometriosis, PCOS, GERD. Her vital signs are here. Heart rate 91, respiratory rate 18, blood pressure is fine, satting 95%. On physical examination, there's really no acute findings, just this complaint of upper back and chest pain. Because you guys can do 12 leads in the field, depending where you are. I'm going to let you guys take a look at this so you guys can think about what you think about these cases while I speak through them. So there's an EKG, take a quick look at it. All right, case number two we're going to talk about. We have a 65-year-old female with shortness of breath and leg swelling. This is a female shortness of breath. She's had bilateral lower extremity swelling for about 5 days. Has a history of an aortic valve repair, a cardiac bypass, hyperlipidemia, hypertension. These are her vital signs on arrival to the ER. She's afebrile, mildly tachycardic, mildly tachypnic. Her pulse oxygen 83%. On physical examination, she has a little tachycardia. She's a little tachypnic. Her lungs are clear, and she does have some lower extremity edema. And this is her EKG. And then the next case is a 65-year-old female with shortness of breath that developed over the last few weeks. So this is a lady with shortness of breath. Over the last few weeks, she's been having worsening shortness of breath. She recently traveled to Alabama, Mississippi, and Georgia by car. She does have a history of hyperlipidemia, and her vital signs are there. She's mildly tachycardic. Her pulse ox is 89%, and on physical examination, she also has no acute findings. And this is her EKG. So when you think about these cases, you guys think about what kind of cases you're looking for. In the emergency department, I always tell the residents the things you have to look for, things that are going to kill someone today, or the most common things. So usually the bigger things we think about are cardiopulmonary diseases, cardiovascular diseases, to make sure you rule those out. So when you go through your whole differential, pulmonary wise, if they're wheezing or have a history of asthma, if they're smokers, could they have COPD? Could they have infectious causes of their shortness of breath, like pneumonias? This right now we're seeing a lot of viruses, a lot of COVID-19, a lot of influenza A. There was a bunch of RSV. We are seeing a lot of other known colds that people are showing up to the ER. One of the big things we're seeing recently as well is pertussis. We didn't see much of that in the recent past, but now it's coming back for some reason. Not really sure why that is, if it's the vaccination rates or not. But if you're not updated with your Tdap, the P in the Tdap is for pertussis. So if you wanted some extra protection and you're not updated, you might want to update your Tdap vaccination. Other big things, pulmonary embolisms, pneumothoraxes, pleural effusions, cardiovascular-wise, you will always think about acute coronary syndromes, heart failure, tamponades. These are the big things we think about, but there's also smaller differentials you don't think about. In the emergency department, we always like to think of a broad differential because you can work people up for all these things. At the end of the day, you may not have any of them. So then you're like, at the end of the day, if you don't think about other things, you're like, well, what happens next? So we always have to think about other things. We've seen a lot of people show up for anemia. For some reason, they have either GI bleeds or maybe they have new onset leukemias. And so they don't have enough hemoglobin around their body to carry oxygen, so they're short of breath from that. People have traumatic things. We have rib fractures, spinal cord dysfunctions. You can't breathe well because you have a diaphragmatic injury because you can't, your nerves aren't, you moving your diaphragm. For persons with myopathies or neuropathies, things like Guillain-Barré. People with new onset renal failure could have fluid overload, so their lungs might be full of some fluid. People with anaphylaxis, angioedema, other infectious causes, you have to think about things like epiglottitis. And then there's the patients who are just psychogenic. That's really a diagnosis of exclusion. So when we see these patients in the ER, just like you, we always start with our ABCs. Like what I was told as a resident, people who are critical when they show up, we kind of like shoot first, ask questions later because you don't have time to ask them. There are many times they can't provide you a history and physical. A history, you get your physical yourself. So if you have to, you stabilize your airway, you intubate them, and then you try to figure out everything elsewhere. But many times that's more of the rare cases that we get. So most people, you can get a decent history and physical, and they say that 80–90% of your diagnosis is your history and physical. So that's why I gave those three cases, so you can think about what you're thinking what those patients might have. Vital signs are a big portion of our workup, the EKG, which I gave you. And when we make our decisions, how we're going to rule people out of certain things, we also have clinical decisions rules. I'll go over some of the common ones we use to try to decide if people have PE or if they're having acute coronary syndrome. There's typical lab work we go. If you go through that differential that I just showed you, things we look at, you look at your comprehensive metabolic panel, which is a CMP. That will tell you if people have things like renal failure, if they have electrolyte abnormalities, if their bicarb's low, they could have some type of acidotic disease. CBCs, really, if they have like a big white count, they have infiltrates on their x-rays, you could say they have pneumonia. If they're anemic, that would pick that up as well. Troponins are for, looking at the, considering if someone's having acute coronary syndrome. The brain natriuretic peptide, the BNP, if that's elevated, that's a sign of elevated heart function. Your heart's working a little bit harder, like in heart failure. D-dimer is something that we test for to help screen for people for blood clots. So when you're thinking about people with pulmonary embolisms, that's something that we order as well. If people come in with fevers, then we also do like a fever workup where we get blood cultures, viral swabs, lactic acid to see how really sick they are, and then some other adjuncts to try to figure out why people are short of breath. X-rays, which we can get immediately in the trauma room, bedside ultrasound, or formal ultrasounds, CAT scan, and nuclear tests like ventilation perfusion scans. Um, so some of the things tools that we use, they have these validated decision rules um, to help rule out certain conditions. So people, if you're young and you're healthy and you come in with a chest pain, if we have a low suspicion that you have a PE, you can kind of use this thing, what we call the PERC rule, the pulmonary embolism rule out criteria. So if you come into me with chest pain, you're like 30 years old, um, your heart rate's less than 100, your saturations are greater than 95%. You're not on any estrogen, you don't have any history of DVTs or PEs, you don't have one leg swelling, you're not on hormones, and you haven't really been immobilized or had surgery requiring hospitalization in the last few weeks, you can effectively rule out someone with a PE just with this rule. If if you're negative, you have less than 2% chance of having a pulmonary embolism. So many young people who present with these criteria, we can effectively say they don't have a pulmonary embolism. If you have a higher risk, then this isn't really a rule that you would use. Other things we use to try to figure out if someone has a PE, there's something called Wells criteria. It's a scoring system. So if you clinically suspect someone has a PE, they would get 3 points. If PE is at least or as likely or more likely than alternate diagnosis, you get an extra 3 points. If your heart rate's high, if you've been immobilized, you had surgeries, you had previous VTEs or venothrombus embolisms, pulmonary embolism, DVTs, what that includes, hemoptysis or malignancies. These increase your risk of having blood clots. So you'd add that up and you'd put them into these different categories. If someone is low to moderate risk, if you can't rule them out with the PERC rule, then you can actually put it, if they're moderate or low risk, you can add that up. And then you can say they have a moderate risk, and you can kind of rule them out using a D-dimer. So that would, that saves you the, unnecessary test of doing a CAT scan or something like that if you have a low to moderate suspicions of PE. That's something we utilize frequently as well. And then if you come with chest pain and you think you're having a heart attack, this is another decision rule that it's called HEART. They look at the history, EKG, age, risk factors, and troponins. And depending on our gestalt, if we are highly suspicious or lowly suspicious, or their EKG changes, we kind of put them in a category. Do we think they're high or low risk? And with the troponin, if it's low, we can get them home that same day because their chance of death within a month is like less than 2%. But once you get to higher risk, then that's someone you'd keep in the hospital to try to make sure they don't have an acute coronary syndrome or an early heart attack. So getting back to these cases, case one, this is a 30-year-old female with shortness of breath, upper and back pain with the tachycardia. So we start to get her tests back, and her troponin is negative, but her D-dimer is elevated. So D-dimer does not mean that you have a blood clot. There are other causes for it, but if you're suspicious of a pulmonary embolism, then you would have to go ahead and order another test to make sure they don't have a blood clot. So that's something you have to think about. Unless there's some other reason why they might have shortness of breath. So you look at her X-ray. Her X-ray, looks pretty normal. So you'd go on to further testing like a pulmonary CT pulmonary angiogram. And this is her CT. And I don't know if you can see my arrow here. There's all this white surrounding this little black area. That is a PE in her right pulmonary artery. And there are others. So if you scroll through more of these images, in the electronic medical record, you'd see she has a lot more PEs than just that one artery. So her diagnosis of pulmonary embolism. Case number two. This is the 65-year-old with hypoxic tachycardic lady. Her troponin's elevated, so she could have, component acute coronary syndrome. Her BNP is elevated, which, means there's some kind of stress in her heart. So she could be having heart failure as well. But her D dimer is also markedly elevated. So you have to do some further testing from there. Her X-ray looks pretty clear as well. So the BNP of the 45 is not really showing up as, pulmonary edema. So, that's probably the less likely cause of her symptoms. So you go on and then you do a coronary CAT scan, and not coronary, a CT angiogram for a PE. And this black area over here. If you can see my arrow, this is what we call a saddle. See how, it's like a saddle going over a horse over this bifurcation of the pulmonary artery. That's what we call saddle embolus. There's a lot of clot over here, and there's also a lot of clot over here as well. So she's got a saddle PE. And then the 65-year-old female with exertional shortness of breath over the last few weeks with the recent travel. For her test, her troponin is also elevated, her BNP is elevated. So once again, could she have early coronary syndrome? Could she have some mild CHF? You have to investigate why she has an elevated D dimer as well. So her X-ray also is nothing really remarkable there to suggest why she's tachycardic and hypoxic. So again, you go to a coronary CAT scan, and then she's got some clot here, and I think there's some clot over here. So my talk today is really about pulmonary embolisms because over the last few years, we've developed a program at the hospital which is different than we used to, and it has very good patient outcomes. So my talk today is mostly about pulmonary embolisms. So PEs is basically a venous thromboembolism. Typically, you get clots in the pulmonary arteries, which comes from other parts of the body. Typically, it's branches from the lower extremities, but you can also have things like thrombus or fat or air, which can cause embolisms as well. The incidence is about 2.18 people per 100,000. It's usually more prominent in males, but I think when you get older females are more prominent as well. And it's thought to cause about 100,000 deaths per year. They can be classified as acute, subacute, or chronic. The acute ones are typically the ones we see in, the ER by ambulance. Subacute ones are sometimes people who walk in or may show up, pretty abruptly as well. The chronic ones are more rare, but I have seen them. A number of years ago, we had a young male who came in with, jaundice. And when they worked him up, he wasn't having a liver problem. He was actually having chronic PEs over a number of years that was caused so much pulmonary hypertension. It was backing, blood back into his liver, caused hepatomegaly, and then caused him to jaundice. So that's something, those are the rare things you have to think about as well, especially if it's been going on for a long time. So when we think about pulmonary embolisms or just even thrombosis in general, like blood clots in the legs or the lungs, we talk about something called Virchow's triad, which is venous stasis, endothelial injury, and hypercoagulable states. These are the three main reasons people get clots in their body. Your body normally has its own process to make clots and then, break the clots up. And it's when you have a dysregulation of that balance of the making and breaking of clots within your body that you start to form blood clots. So when you have things like venous stasis, like when you're sitting, like if you're a hospitalized patient, if you're sitting in a plane, blood pools to your legs, so you get venous stasis, and that makes you more likely to have blood clots. Endothelial injuries, people who have like surgeries or traumas, that also makes them more likely to have blood clots as well, since there is inflammation. With inflammation, sometimes you can get extra clotting. So that's why that's another one of the triad features as well. And then people with hypercoagulable states, people with cancers and things like that, or people with thrombophilias where they're more prone to blood clots. So if you look at, subgroups of people who are prone for clots, I mean, they all fit Virchow's triads. Malignancies, as I mentioned, you're hypercoagulable. As a pregnant patient, you're hypercoagulable. As a hospitalized patient, you're kind of, many times you're very sick, you're just kind of laying there. So we have programs in the hospital to try to prevent blood clots. It's either with heparin, typically we do, or if you are not eligible to get heparin, we have these compression devices that will squeeze in your legs, and what that does is basically pushes blood back up towards your heart. Um, so that's the one way that we do it. If you're on a plane for a long time, similar to that, for long trips, you should probably, try to squeeze the muscles in your legs and get up and walk around so you don't, so, to try to do the same thing as those compression devices to prevent any pooling of blood in your legs. That's why you should always get up and walk around on long plane trips in the cabin if you get a chance to. People with nephrotic syndromes, for some reason, they lose a lot of, well, for nephrotic syndrome, you do lose a lot of proteins from your kidneys, and a lot of those proteins that you're losing help anticoagulate the blood, so that makes you more prone for blood clots with nephrotic syndrome. People with spinal cord injuries, obviously, they're not walking around as much, so they're also prone to venous stasis. People with joint arthroplasties or replacements, many of them aren't getting up and moving around. Now they put a lot of these people on anticoagulants for a few days, or a few weeks, just prevent them from getting blood clots. And then they also have inflammation in the lower legs, so they're more prone for clots as well. And then the people with inherited thrombotic disorders are also higher incidence. But all these classes of people who have higher incidence all fit under these the triad of the venous stasis, endothelial injury, and hypercoagulable states. So the source of most pulmonary embolisms are usually from the lower extremity proximal veins, usually the iliacs, the femorals, and the popliteals. There are a lot of, but they're estimated about 50% of patients who have DVTs probably have concurrent PEs. Some of them silent, some of them not. They don't have any symptoms of a PE, and their vital signs are okay. It's the same treatment if they have a blood clot in the leg or the lungs. So many times you won't fully work them up for a PE. If they have any signs, then of course we definitely get some type of imaging to see if they also have concomitant PE with their DVT. Veins are lower in the legs, like the calf veins. They rarely embolize, and most of them resolve spontaneously. And there's been debate, do we actually anticoagulate these patients? But I think most people do, just to prevent them propagating and becoming bigger and making them to the heart. So what's the big problem with pulmonary embolisms when the clots go to the lungs? First of all, you get clots that are obstructing the abnormal, the airways, causing abnormal gas exchange. So you start to get things like hypoxemia. If the clots are big enough, you can, prevent blood flow through the heart to the rest of the body. So that can actually cause hypotension. And then in some patients, if you cut off the blood supply to certain parts of the lungs, you can actually get pulmonary infarctions. That's where some people get chest pain and hemoptysis. So with PEs, the clinical presentation, there are people who are asymptomatic, like I said, there are many people with DVTs who may have PEs, but they don't know about it. Or there are patients who have come in with cardiac arrest, or pericardiac arrest, who are in shock that end up having PEs. There's a study called the PIOPET study, and they looked at a lot of these patients with PEs, and these are what they found were the most common symptoms. Dyspnea at rest was with exertion is the most common one, followed by pleuritic chest pain, coughing, orthopnea, thigh pain or swelling, because typically the clots come from the legs. Some people may have wheezing, tachycardia. Some can have rales or decreased breath sounds. Only a small percent of patients have hemoptysis. Other less common things that you see, but we do see them in the ER. We've had people with AFib who've new onset AFib who've ended up having pulmonary elements when you work them up. People who pass out who have presyncope or syncope, it's also not a good sign when they pass out because they are prone to more likely to have hemodynamic collapse. EKGs for PEs, majority of them are really non-specific, but patients, who have EKGs with the following signs are really poor prognostic indicators. So people with atrial arrhythmias, like when you have people with AFib, if they have brady or tachyarrhythmias with the PEs, a new right bundle branch block, that's because you're getting elevated pressures in the right side of the heart. which can strain the heart to cause a right bundle. You may see inferior Q waves, and the big thing that a lot of people talk about is an SQ, S1, Q3, T3 pattern. Um, so there's an EKG, and it's someone with a pretty large PE. These are the anterior T wave inversions and ST segment depressions you get. If you look over here in 2, 3 and AVF, um, there's a there is there's an S in oh sorry there's an S in one, a small Q in three, and an inverted T in three. So that's the S1 Q T3. Okay, so when we're working up the patients, certain special tests that we also get in the ER. A lot of times we'll get an EBG, also with the pulse ox, which could show hypoxia. A widened AE gradient is basically when you can calculate how much oxygen someone should have in their blood by the percent of oxygen that you're providing them. And if there's a difference in what it's as expected and what you're giving them, that's what we call an AE gradient. You can also see things like respiratory alkalosis and hypocapnia, just from them breathing so fast from having the pain and the pulmonary embolism. Troponins and BNPs are things that we order in patients with PEs, not to help diagnose the PE. They're kind of prognostic indicators of PE. So if you have a higher troponin or a BNP in patients with BNPs, there's signs of right heart strain. That means it's a pretty big clot, and you probably have to do more sooner than later with those type of patients. Other things that we do in the workup, chest x-rays, majority of them are non-specific. These are more specific things when patients have them. So if you look at this x-ray on the left, one side of the lung is much darker than the other. So the white parts on the left are usually pulmonary blood vessels. On the right, since there's such a large clot, this is what we call a Western mark sign, because it would be called oligemia. That means there's really lack of blood flow to that lung, and that makes it more black. So this is like a sign suggestive of PE. If you look over here, if you can see where I'm tracing, there's this little white area here. It's what we call Hampton's hump. That's typically occurs when you have part of your lung is infarcted. So these are the subtle things you may see. Oh, this one's not so subtle. This one's more subtle. Of things we might find in x-rays suggestive of PEs. Further working up patients in, part of our workup, you're going to have to get an echocardiogram, either a formal one or a bedside one. If you watch us in the trauma rooms, many times we'll pull out the ultrasound machine, some of the things we're looking for. So for the ultrasound on the left, if you see this circular here, this is the muscle of the left ventricle. This is a normal one. It's supposed to be nice and round, and when it squeezes, it stays round. This over here is what we call the D sign. Here's the straight line, and here's a little curve of the D. This occurs with a patient with a large PE because this is the right atrium, right ventricle, and there's so much pressure in the right ventricle from pulmonary hypertension that it actually pushes on this interventricular septum and makes this appearance. So that's suggestive of pulmonary embolism. And over here on the right, this is another echocardiogram, which kind of shows this is the right ventricle and this is the left ventricle. The left ventricle is always bigger muscle because it's pushing blood through the entire body. This is typically always bigger than the right ventricle. So they talk about the RV to LV ratio. It's usually less than 1. This is much bigger, so this is suggested of pulmonary hypertension, which could be due to a PE as well. These we typically can do at the bedside. Many times, we'll get formal ultrasound by the radiology department because not everyone's, fully trained to use ultrasound in this specific way. So other tests that we use are ventilation perfusion scans. These are less used. They're morally, this is one of them. I don't really know how to read them, but suppose there's a blood clot somewhere in there. These are pushed more out of in favor for angiograms. But people who have kidney problems and things like that, and if they can't get an angiogram because the dye can affect their kidneys more, this is something we would do. We would treat the patients empirically for a blood clot and then try to obtain one of these tests. Previously, they used to do formal angiogram, but those are kind of being replaced by CT angiograms for a lot of PEs. And, Similar to the case I showed you before, this is actually a different case where someone had another saddle embolus. But this is basically the main test that we do to rule in or rule out a PE these days. So as I mentioned, over the last few years, there's some newer treatment modalities when patients came to the hospital. Before, really, we had anticoagulation with heparin for the stable patients. We have TPA, which we still use intermittently for patients who have massive PEs and they're unstable. So there was TPA. If they weren't eligible for TPA and they were unstable, we'd have to refer them out, transfer them to another hospital to get what we call mechanical thrombectomy, where they would put a catheter in someone to try to extract the blood clots. That was before 2020. So since then, we've added a bunch of things to our armamentarium at Good Samaritan Hospital. Now we have a bunch of whole catheter-directed therapies. We can do thrombectomies, or we do catheter-directed thrombolysis with TPA, with ultrasound, with some good results. So if you come to the hospital today and you're diagnosed with a pulmonary embolism, we actually have something called a pulmonary embolism response team. This typically includes the medical ICU attending, our pulmonology attendings, interventional cardiology attendings, our cardiothoracic attendings. The reason why, because previously, before we had these therapies, if the patient was unstable and we couldn't give them TPA, we could actually refer the patient to cardiothoracic surgeons who would actually do an open thoracotomy and get into the pulmonary artery after putting the patient on bypass to extract the clots out of the lungs. But now, with the help of interventional cardiologists, we have these percutaneous techniques that we can use to treat patients with PEs. And since it's such a specialized team requiring like interventional cardiologists and cardiothoracic surgeons, which they don't have in smaller hospitals all the time, we're actually a referral center for the other Catholic health hospitals to have these procedures done. So when you talk about treatment, you always have to break them down. Are they stable or not stable? If they're not stable, it basically means they're hypotensive, the blood pressure is under 90, or they have a significant drop in their baseline blood pressure by greater than 40 points. If there's clear evidence of shock just by examining or they require vasopressors to keep their blood pressures up, they're considered not stable. Stable meaning they don't meet the above criteria, and if they're stable and those markers I talked about, if they have signs of heart strain, either an EKG, on a bedside echocardiogram or a formal echocardiogram, we call a PERT echo, and their BNPs or troponins elevated, those would be what we call a submassive PE. Those are difficult to try to decide how to treat because you don't know if they're going to become unstable or not. So it's because of that we have this PE team, response team, and they look at the patients individually and then they decide what's the best treatment course for them. So stable patients are kind of easy. They're not unstable, so you can really just start them on IV heparin. Once you start on IV heparin, you usually get admitted to try to figure out the etiology of your pulmonary embolism, and then you get transitioned to oral anticoagulation and eventually discharged home. When you start to have the unstable one, they usually need oxygen, IV fluids. Typically, if they're unstable and there's no contraindication, they can get thrombolytic therapy. The problem with thrombolytic therapy, if you're familiar with giving thrombolytic therapies for strokes, there's a lot of contraindications, the relative contraindications. This is because TPA not only breaks up clots in just where they're not supposed to be, they break up clots all over the place. So if you had any recent surgeries, any history of intracranial hemorrhages, any history of intracranial neoplasms or ischemic strokes, aortic dissections, or other bleeding diatheses, you can't really get that. So if you're unstable and you can't give TPA, you're kind of like in a no man's land until they develop these new therapies. Unless you got an open thrombectomy where you're talking about they're opening up your entire chest to try to get to that clot. There's also a lot of relative contraindications, which makes it difficult to try to decide how are you going to treat the patient as well, because then you have to think about all these things: uncontrolled hypertension, the history of strokes, recent traumatic injuries or prolonged surgeries? Did they have recent procedures? All these things make you more prone to bleed as well. Pregnancy is a relatively contraindication, so you wouldn't give TPA to them, though you could. Things like pericarditis, pericardial fluid, you can bleed more around the heart. So when you call the PERT team, these are all the things they think about and the best way to treat someone. Do you give them a TPA, or should you go to one of our newer therapies that we're doing at the hospital now? So two of the catheter-directed therapies that we use, one is called ECOS. I have some videos here if just to try to give an idea of what exactly they do. But basically, I'll tell you quickly, I'll let you watch the video. So ECOS is basically where they put these catheters into your pulmonary arteries, and then they put you in an infusion of TPA to try to break up the clots. But then that's also augmented with ultrasound to help break those clots up. Through some trials, it showed you get reduced risk of bleeding if you give TPA catheter directed. It reduces the clot burden, improves the RV dysfunction, and also reduces long-term pulmonary hypertension. Let me see if I can get this to work here. Sorry. Do I have to change the share screen, Justin?
Yeah, when you click on the link, go
Um,
back to the share option and it should show you.
Let me share. Here we go. Can you see that?
I see it, but I don't know if we're going to hear it. Let's see.
What we're going to do today is treat a
Yeah,
60-year-old
you got it.
obese female patient with a massive pulmonary embolism with catheter-directed thrombolysis with an ultrasonic component. This patient was admitted to the emergency room this morning after a syncopal episode and shortness of breath. A CAT scan was performed, which showed a massive saddle pulmonary embolus with extension in the right and left pulmonary arteries. The CAT scan obviously shows an enlarged
Press the full screen option just so it
RV-LV
expands.
ratio greater than 2, and we feel that she is an excellent candidate for this procedure, which is a
What'd you say, Justin?
procedure in order to lyse the clot in a pulmonary
Press
artery.
the full screen option so it expands.
Venous access is then obtained in the usual fashion.
Full screen?
Once the needle
Yep,
is
you had it there.
an 035 guide
I had it?
wire is then
Bottom
inserted.
right of the video that's playing. That's square.
Over
Yep.
the guide wire is inserted a 10 French sheath with 2
It
ports.
didn't go.
This
Okay.
allows us single groin access for both of the 6 French ECOS catheters. We then insert an 035 guide wire with a directional catheter, position this across the tricuspid valve, the pulmonary into the right ventricular outflow tract, and as seen here, into the left pulmonary artery.
I think I screwed something up here.
Wire is left in place, the catheter is removed, and the IDDC, or the intelligent...
Try clicking on the screen.
Say again?
Is inserted
Try clicking on the screen to exit full screen.
Appropriately into the left pulmonary artery. The microsonic delivery
All right.
catheter
Can you see that now?
is then
Yep.
inserted through the IDDC. The microsonic delivery catheter is composed of ultrasonic transducers spaced 1 centimeter apart. The catheter, the MSD is then secured to the catheter. The second catheter is then inserted through the other port. And once again, the guide wire, with the use of a directional catheter, we like to use an angled pigtail catheter, is put in position in the right pulmonary artery. The catheter is removed, and once again, the intelligent drug delivery catheter is inserted over the 035 wire and positioned appropriately. The guide wire is then removed, and the microsonic device is once again inserted and secured to the delivery catheter. With the two catheters in place, the IDDC or intelligent drug delivery catheter and the MSD microsonic device are attached to the cables that will attach to the PT3B ultrasound control unit. The units are then activated, the ultrasonic energy commences, and at this time, a bolus dose of TPA is given down each of the catheters. I like to use 4 milligrams bolus dose down each catheter. After the bolus dose is given, the TPA drip is attached to each of the drug ports, and the patient is brought to the intensive care or coronary care unit for observation. Our patient was typical of the last 28 patients treated in this fashion, demonstrating clinical improvement within 1 hour of treatment. She was totally asymptomatic at 6 hours. Our 48-hour follow-up CAT scan shows a marked reduction in thrombus, however, some is still present. What is most interesting in this patient, however, is that the RV-LV ratio is markedly different from the first study. This CAT scan 3 weeks later shows virtually no thrombus remaining in the pulmonary circulation, and the RV-LV ratio now is less than 0.9.
Were you guys actually able to see that? Hello?
I was able to see it. It froze a little bit towards the end, but I did see it.
Okay, all right, just wanted to make sure. Because at one point it said it wasn't, it said it was paused. Where is my other, here we go. So that's one of the things we've been doing the last few years. And even you were, no. You're seeing my presentation again?
Yep, it's back up.
Yeah, oh. We do a catheter-directed thrombectomy. It's called Inari because that's the name of the company who did it. There's studies, the FLAIR study that showed that monotherapy or combination with lytic therapy, it has rapid thrombus removal and has improvement of pulmonary artery pressures and oxygen saturations without the complications of thrombolysis. So let's see if we can get this one to work.
Inari Medical FlowTriever is the first mechanical thrombectomy system indicated for treatment of pulmonary embolism, uniquely designed to engage, disrupt, and extract venous clot. The Triever 20 features a highly trackable, large lumen catheter and large bore syringe designed to rapidly extract large volumes of clot while limiting blood loss. The FlowTriever catheter features 3 self-expanding nitinol mesh discs in 4 varying sizes that are designed to engage, disrupt, and deliver clot to the Triever 20 for extraction. Upon gaining ultrasound-guided venous access, a guide wire is advanced past the target clot in the pulmonary artery. With the dilator in place, the Triever 20 is advanced over the wire until it reaches the target clot. The dilator is removed, and with the flush port stopcock closed, the syringe is pulled back and locked into place. Opening the stopcock releases the vacuum and creates a high-flow, volume-capped aspiration, minimizing blood loss, while drawing clot through a continuous lumen into the syringe. If clot remains, the appropriately sized FlowTriever catheter is then introduced. As the catheter is retracted, the nitinol discs self-expand, engaging the clot from within. Retraction of the atraumatic discs liberates clot from the vessel walls as it is delivered back into the Triever 20. The Inari Medical FlowTriever system is designed for the removal of significant clot burden without the need for thrombolytics or consequent ICU stay.
Yeah, so that's another exciting thing we've been doing at Good Samaritan for people with permanent embolisms. Let me get you back to my other screen here. So this is actually pictures of patients we've had in the ER. This is where the big clot is, and they put the device in, and afterwards.
Group donor Brett Sessel has had enough of a used car shell game. I see most dealers. They show you one price on a pre-owned vehicle, and when you go to pay, they add on a bogus fee.
Sorry about that. It says I'm failing to share. What are you guys seeing right now?
Still just you, not the presentation though.
Back on here.
Try it again. I just made you a co-host. There you go. It's coming up.
Okay. Yeah, so these are actual cases. What I guess like the company likes to do when they pull out the clots, they have these branches of the pulmonary artery on a photo, and they have the proceduralists actually take out the clots and show you where the clots came from. So this is one of the patients we recently had in the ER that had a large right lung pulmonary embolism. So going back to our cases, the first person, she had an echocardiogram, we call it PERT echo. She had no signs of heart strain. So she was treated with high heparin, eventually discharged on an oral anticoagulant. She had recent surgery, so that's what we consider a provoked PE. So she'll be in heparin for at least 3 months, and then after reevaluation, 3 months, they decide if she needs anticoagulation anymore. She was discharged after hospital day number 4. Case number 2, this is a lady, I believe 65-year-old lady, had elevated troponins, BNP. Her echocardiogram showed that her right ventricle was severely dilated. She had reduced systolic function suggestive of increased pulmonary pressures. So she had what we call a submassive PE. She was started on IV heparin. She had a thrombectomy with INR procedure. And this was her clot that they pulled out of her. So pretty big clots on her, right? She was eventually switched over to oral anticoagulation and discharged on hospital day number 5. This lady, she had no travel. She's the one who didn't have any surgeries. So she had what we call a non-provoked PE was assumed, pending some other workup on the hematologist to see if you have a hypocoagulable state. And, she may be in anticoagulation for the rest of her year since it's unprovoked. And then case number 3, this is a lady with the travel. Her echo also showed she had a dilated right ventricle, suggesting she too had right heart strain. So she also went through a thrombectomy and was eventually discharged in an oral anticoagulant. But she also had a provoked PE from her trip. So she'll likely be in at least 3 months of anticoagulant therapy, and then reassessment after that to see if she continues to need it. So pulmonary elements at discharge, when their patients are stable and they're starting their anticoagulation, as I mentioned, they're on it for at least 3 months. Most patients today are usually on things like apixaban, which is Eliquis, or roxaban, which is Xarelto, instead of things like Coumadin, since they're once or twice a day dosing and there's no blood work you need like Coumadin. So Coumadin is slowly disappearing. There are certain patients who can't take NOACs, like pregnant patients who will need to be on low molecular weight heparin, which are just injections they have to do daily at home. And then there are some patients who aren't even eligible for some type of anticoagulation. If you're considered a fall risk and things like that, they just may put an IVC filter in you. But these are more on the rare side because most people can, tolerate the anticoagulants. But if you have some contraindications like a fall risk, they may decide to put an inferior vena cava filter in you. And I think that's pretty much my presentation. So just to review, PEs are these blood clots that end up in the lung, typically from other parts of the body. It's a very varied presentation. It can be like acute to sudden arrest to period arrest, where they can show up in the hospital, where they can have like minimal to mild symptoms. Our diagnosis, basically, we have a lot of clinical tools, echocardiograms, CAT scans, and things like that, where we may help make the diagnosis. And what I think is important to know is we have a specialized team at the hospital, who works as a big team to try to figure out the best treatment options for you. So it's a great thing we do at the hospital to help the community with these patients with these life-threatening pulmonary embolisms. And I think that's pretty much it. You guys have any questions? If not, I'd like to thank those of you who showed up for my presentation. I hope you learned something from it, and have a good evening.
Thank you, Eric. Thank you, everybody, for joining. We'll be posting this also in the upcoming week, and we'll be sharing it with all the EMS agencies. So thank you again.